and something, why is it coming NNF faculty?
I will change the name. So,
Hi, Dr. Amit. How are
Hello,
you?
Dr. Sapna.
Good evening, ma'am.
Good evening.
You can share the flyer if there is nothing else to show, then so that people know that what session is about to start. Dr. Pratima has joined. Not yet. Dr. Ramesh is not here as well today.
I think Dr. Saurabh has already said both of them won't be there today. Dr. Ramesh.
Two more minutes. We shall wait. 8:05. We can start. So it's a very interesting topic. Dr. Mangla, as a clinician, I was
Yes, sir. Actually, definitely a very simple intervention, and actually, we also hope that the trial helps in
mortality. Is that too far-fetched, or is it coincidental, or is it actually a wonder drug, wonder vaccine which we were looking for? It reduces not only tuberculosis, but it reduces neonatal mortality. Wow. So it should be the vaccine of the year. Again, it is going to be out by 2030. Then it will come over as a vaccine to prevent neonatal mortality in VLBW babies or LBW babies.
Yes, sir. Definitely, sir. We believe.
What does BCG do? Reduce neonatal mortality.
Yes, sir. Definitely. We believe so, sir.
So, I couldn't imagine it doing so in first case. So I'm very keen on listening to this interesting topic, interesting channel club. And my question to the faculty and presenters would be just the same, that what is the probability of this being a coincidental finding as opposed to a real preventer cause and effect relationship?
Yes, sir. Definitely. I think those questions will come up, and I think that hopefully that will be discussed today.
So it's 8:05 now.
Okay, sir. We'll start, sir.
Yes, Dr. Sindhu, over to you.
Sure, sir.
So this is the fourth session of monthly NNF Journal Club.
Exactly, sir.
So this month, we have a very good topic: effect of BCG vaccination on BCG and OPV on neonatal mortality in newborn babies under 2000 in India. One of those papers in which highlight that multi-center trials, RCT like good trials, are routinely being performed in India by collaboration through different hospitals and medical colleges. And so to discuss this paper, we go on to Dr. Sindhu to please begin the session and lead the way.
Thank you, sir. So as you rightly pointed out, that we'll be discussing the randomized control trial, the BLOW-2 trial. We are honored to have with us Dr. Shriparna Basu, Professor and Head, Department of Neonatology from AIIMS Rishikesh. And the speaker would be Dr. Gaurav Gautam, who will lead us through the critical aspects of the trial. We also have with us our expert discussant for the evening, Professor Dr. Deepak Chawla from Government Medical College, Chandigarh. We deeply value his expertise and look forward to his perspective of the study. And we are very privileged to welcome the investigator of the Blow 2 trial, Dr. Professor Mangala Bharati sir, who will also help us understand the nuances of the trial, the challenges that he encountered, and the future directions. I will also like to acknowledge and welcome the leadership of the NNF Research Committee, Professor Dr. Saurabh Datta, who is the chairperson, Dr. Ramesh Agarwal, coordinator of the NNF Journal Club, and Dr. Pratima Anand, the co-coordinator, and Dr. Amit Upadhyay, the General Secretary, NNF. Thank you, everyone. We look forward to an engaging and insightful academic session this evening. Over to you, ma'am.
Good evening, everyone. I am audible.
Yes, ma'am.
Okay, thank you. So today, as Dr. Sindhu has already mentioned, we are discussing Blow 2 trial, BCG in low birth weight babies. And why we have chosen this study, because all of us, it's a trial of our own. All of us can relate to it. It's our day-to-day problem. All of us are facing, especially those who are in busy government sectors. We are facing the lot of like huge population of low birth weight and high mortality, and that too infection-related deaths. And the authors have shown that a simple intervention like giving BCG vaccine, which all of us do, just a change in time and change in dose can bring the miracle and can reduce the mortality, especially the infection related deaths. That is the reason we are discussing the trial. Of course, it has been published in BMJ and it's in Indian context. That is the added charm of it. So to present it, we have Dr. Gaurav Gautam, who is our third year DM neonatology SR. So Gautam, Gaurav, you can.
Yes, ma'am.
Gaurav,
Good evening.
you can
Good
share
evening
your
all.
screen.
Yes, ma'am. So, is the screen visible to all?
Yes, you can start.
Good evening, all. Welcome to the monthly NNF Journal Club. My moderator is Dr. Shipanna Basu, and my faculty is Dr. Deepak Chavla, sir. For this journal club, we have selected this article: effect of BCG Danish and oral polio vaccine on neonatal mortality in babies, in newborn babies weighing less than 2 kgs in India. It is a multi-center, open-label, randomized controlled trial by the acronym of BLOW 2. It was published in BMJ on 22nd of September 2025. So BLOW 2 stands for BCG in low birth weight neonates trial 2. It's a multi-centric, open-label, randomized controlled trial. There have been no external funding and no competing interest declared. As we already know that around 5.2 million deaths of children less than 5 years occurred in 2019, out of which 98% of this under 5 mortality were in the LMICs, and 47% of these under 5 mortality were in the neonatal period. So interventions to reduce neonatal mortality is needed urgently, and BCG vaccine has been shown to be beneficial and has off-target effects on neonatal mortality. Along with tuberculosis, BCG vaccine reduces the severity of other infections. These beneficial non-specific effects of the BCG vaccines are due to heterologous immunity and trained innate immune responses, which is mediated by epigenetic reprogramming of the monocytes and enhanced in existing immunity, like maternal BCG scar. It depends on the BCG strain used and can last for 1 to 2 years and may have some seasonal variations. As we can see in this diagram, this is depicting the trained innate immune response of the BCG. What does the BCG causes epigenetic remodeling in the monocytes, macrophages, which are the building block of the innate immune response. But these monocytes, they don't have any memory. But after exposure to the BCG, there is epigenetic remodeling, which ultimately leads to active gene expression and augmented gene expression, which ultimately leads to trained innate immunity, increased microbial killing, increased cytokines, and also helps in adaptive immunity. So there are various BCG strains which are different in their RNA content and immunological effects. There have been mixed results of previous studies of BCG in reducing neonatal mortality. The meta-analysis of 3 trials of BCG, they showed that they reduced neonatal mortality by 38%, and 2 other prematurely terminated trials in Guinea-Bissau. One trial was of Danish strain, which showed no effect on in-hospital mortality, and the other trial was of Tokyo strain, which showed possible reduction or in mortality up to 60 days. Whereas the trials of BCG Russian strain in India, they showed no effect on neonatal mortality. This table summarizes the previous trials of early BCG vaccine. The first 4 trials, which were done with BCG Danish strain, showed no effect on either infant mortality or neonatal mortality. Whereas the fifth trial, which was stopped prematurely, used early BCG Tokyo strain, and it showed decreased mortality up to 60 days of age. The 2 Indian trials which were done in Chennai and Pondicherry, they also failed. They used BCG Russian strain, and they also failed to detect any significant difference in neonatal mortality. This was a multi-center open label RCT done in 3 large NICUs in Southeast India, that is JIPMER Pondicherry, Institute of Child Health, and Institute of Obs and Gynae in Chennai, during the period of February 2017 to April 2022, and it was prospectively registered in CTRI. The population were newborn babies weighing less than 2 kgs. Intervention was early vaccination group, that is BCG and OPV, given within 48 hours of admission to the NICU. Control group was delayed vaccination group, in which BCG and OPV were given at the time of discharge, and the outcome was all-cause neonatal mortality in the first 28 days of life. Neonates less than 60 minutes or 21 days of age, unlikely to survive for 24 hours, major life-threatening malformation, already vaccinated with BCG, mother or baby known to have HIV, hepatitis B, herpes zoster, or any immunodeficiency, mother aged less than 18 years, or with respiratory symptoms suggestive of TB, and family refusal of consents. These neonates were excluded were excluded. So the sample size was based on the absolute number of deaths. So the expected reduction in the intervention group was 30%, with a power of 95% and alpha error of 0.01. Total deaths needed to detect the difference was 510. Randomization was computer based, stratified by NICU, sex, and birth weight. Block sizes varying randomly from 2 to 8 newborn babies. BCG vaccine causes an obvious skin lesion, so masking was not possible, and caregivers who assessed whether the baby died or survived were not blinded. Procedures: in the early vaccination group, 0.1 ml of BCG Danish strain intradermally and 2 drops of bivalent OPV were given within 48 hours of NICU admission, and in the control group, the same vaccines were given at the time of discharge. The primary outcome was neonatal mortality in the first 28 days of life, and the secondary outcome was deaths caused by infections and deaths in newborn babies of mothers with a BCG scar. Censoring was done at the time of loss to follow-up or any vaccination within 28 days other than BCG or OPV. There were pre-specified lists for cause of death, that is congenital malformation, hyaline membrane disease, infection, intraventricular hemorrhage, NEC, others, and unknown. So infection was defined as one or more clinical signs suggestive of infection with either a microbial isolate on blood culture or sterile blood culture plus at least 2 abnormal infection markers like CRP, ANC, TLC, micro-ESR, and IT ratio. Statistical analysis was done intention to treat, and all statistical tests were two-sided with a p-value of less than 0.05 being significant. Cost proportional hazard models were stratified by NICU with age as the underlying time. Pre-specified binomial covariates were tested for proportional hazards in Kaplan-Meier analysis. Potential for non-linear relations in the continuous variables were assessed using fractional polynomials. Proportional hazards assumption of the Cox model was tested using time interaction, Schoenfeld residuals, log-log plots. These were used to confirm the validity of the Cox model, and it ensured that comparison of the risk between the groups remains stable over time. So out of total 7067 neonates less than 2 kgs, 1647 were excluded and 5420 were randomized, out of which 2714 neonates were randomized to the early vaccination group and 2760 were randomized to the control group. In the control group, 1588 neonates received the BCG vaccine at less than 28 days. Total number of deaths were 238 and 273 in the early and the control group, respectively. Total deaths were 511. A total of 10 participants suffered protocol violation, 7 in the early group and 3 in the control group. So baseline characteristics: median birth weight, median gestational age were similar across both the groups. The proportion of very low birth weight and extremely low birth weight neonates were similar across both the groups. The proportion of inborn babies were 90% in both the groups, and JIPMER contributed to almost half of the population in the participant group. Almost half of the neonates were born in the wet season in both the groups. Primary outcome: the all-cause mortality was 1.29 in early group and 1.5 in the control group. The adjusted hazard ratio being 0.83. Death from infection was 0.4 in the early group and 0.7 in the control group. The adjusted hazard ratio being 0.53. Deaths in hospital were 2.3 in the early group and 2.69 in the control group, with the adjusted hazard ratio being 0.83. And after the per protocol analysis, the adjusted hazard ratio was 0.77. This is the Kaplan-Meier analysis curve showing the probability of death in both the groups. The adjusted hazard ratio was 0.83, and number needed to prevent one death was 21. The table shows the time for vaccination and death. So median time from birth to vaccination in the early group was 0.9 days, and in the control group was 12.6 days. Median time from birth to death in the early vaccination group was 6.41 days, and in the control group was 5.99 days. Among the various causes of death, 31% of neonates in the early vaccination group died due to infection, and 49% in the control group died due to the infection, making BCG to control ratio of 0.55. So this table shows the effect of pre-specified risk factors on mortality. None of these pre-specified risk factors were clinically were significantly contributing towards the mortality, but there was trend towards better outcome in early BCG group in all birth weights. Even in term babies, the mortality rate was 0.41, and in preterm babies it was 1.43. Similar findings were seen in male versus female, inborn versus the outborn, presence or absence of the maternal BCG scar, and cesarean versus vaginal delivery, and also according to the season. So interpretation of these results: BCG Danish and OPV administered in neonates less than 2,000 grams at a median age of 0.9 days reduces all-cause mortality by 17%, neonatal mortality due to infection by 47%. NNT to prevent one death was 21. There were no tuberculosis-related death observed, making that effects of BCG were non-specific. BCG Danish strain was most beneficial if administered early, and in some newborns, it may be treating and not just preventing sepsis. So strengths, it was a multicentric RCT with a robust study design, with considering a large sample size, done in NICU where mortality is high and BCG vaccination is often delayed. It was a rigorously conducted trial shown by that 97.4% of participants has had visible skin reaction to BCG. Intervention may be feasible in all settings, even in the SNCUs, and there are widespread applicability of these results. Limitations: it's an open label trial. OPV which is given with, may be a confounding variable or an effect modifier. Results may not be generalized to the extremely low birth weight or extremely preterm babies, and the dose 0.1 ml BCG is not a standard dose for neonates, and it needs further exploration. Implications: Danish strain has been shown to be most effective among all strains. Early BCG vaccination to all neonates, regardless of gestational age. Restrictive vial policy leads to delay in BCG vaccination, which is not desirable. BCG skin reaction should be given importance for adequate vaccination, and there is a need to incentivize early and correct vaccination. And additional trials are needed to compare different BCG doses and strains, and to test the effects of revaccinating infants with no BCG scar. This is the BCG protocol that is followed at AIIMS Rishikesh. We use Danish strain. The dose is 0.05 ml intradermal till 1 month of age and 0.1 ml thereafter. It is administered by a trained vaccination staff in the left upper arm. So the timing, the babies which are being cared in the postnatal ward, they are being vaccinated at the earliest opportunity, and the babies in the NICU, they are vaccinated when they are clinically stable of antibiotics within 14 days or at 6 weeks BNA. Restricted vial policy is applicable for at least 5 babies to open 1 vial, and there is no concept of revaccination. So implication of this study in our settings: we are using the same strain as it has been used in the trial, but the dosing is different. We are using 0.05 ml, and they have used 0.1 ml in all neonates. There have been some reservations regarding OPV administration inside NICU, and the feasibility of opening a BCG vial even for a single eligible baby is debatable. These are the various guidelines for BCG vaccines. WHO recommends 4 strains, that is Danish, Moscow, Tokyo, and Sofia, which has been recommended both by IAP and NIS. The dosing is similar, 0.05 till 1 year of age, as per WHO, and 0.055 ml till 1 month of age, as per the IAP and NIS. The route is similar, intradermal, and it is given in the lateral aspect of the upper arm. Indications, as per WHO, all healthy clinically stable neonates more than 31 weeks are eligible, and as per the IAP, more than 32 weeks when clinically stable or at discharge. Restrictive vial policy is applicable for both WHO and NIS, but IAP does not recommend on restrictive vial policy. There has been no concept of revaccination in all 3, like WHO, IAP, and NIS. CAS checklist. Did the study address a clearly formulated research question? Yes. Was the assignment of participants to intervention randomized? Yes. Were all participants who entered the study accounted for at its conclusion? Yes. Were participants, staff, and study personnel banded to study group? No. Were the study groups similar at the start of the RCT? Yes. Apart from study intervention, did each study group receive same level of care? Yes. Were the effects of intervention reported comprehensively? Yes. Was the precision of the estimate of the intervention reported? Yes. Do the benefits of the experimental intervention outweigh the harms or costs? Can't say. Can the results be applied to your local population? Yes. Would the intervention provide greater value to the people in your care than any of the existing intervention? Yes. Now, the relevant statistics which have been applied in this trial, censoring. So participant is censored when the information on time to event is not available, like loss to follow up, discharge early. So basically, it is non-occurrence of outcome event before the trial ends. In survival studies, censoring means we stop counting the baby's time at risk before the study period ends. Time to event is counted only up to the event, up to the point they were censored. And censored participants contribute to whatever time they were truly followed. It allows for fairer comparison of event rates over time, and the results are more accurate. Now, sample size calculation based on the outcomes accrued. So, if the endpoint is time to event, that is like survival. So we use Schoenfeld log rank approach or Stata's power log rank command. If endpoint is a binary proportion at fixed follow-up, then we use two proportion sample size formula or Stata's SAMC command. If endpoint is an incidence rate, then we use Poisson or rate comparison formula. Thank you.
So wonderfully presented.
Thank you, sir.
So we go over to the faculty, Dr. Shiparna Basu, madam, for your comments and
So regarding use of the results of the study at our settings, we can make two changes. One is, of course, the timing we can change. All our babies get vaccinated, but like in postnatal ward, they get at earliest opportunity. But in NICU, we have some reservation that we can change. We can vaccinate all of them by 48 hours of admission. That is feasible. Regarding dose, we have not used 0.1. We are consistently using 0.05 ml. So there maybe you all can voice your opinion whether we should make this change. And there are some references given in this study where there are quite a few studies from Delhi, mostly from North India. They have said that they have used 0.1. But whether there is an extra benefit of using 0.1 over 0.05, that is debatable. And one more thing, again, there is some reservation of using oral polio vaccine, live vaccine in NICU. Like there is age-old teaching that there can be vaccine-induced polio, though we are using now bivalent polio vaccine and strain 2 is eliminated, so that can be used. So these two changes we can do. One is timing and second is dose. And third is, of course, adding OPV along with BCG. Otherwise, it will be unnecessarily delayed. If we do not give it together, we cannot give it.
any
So
other
that
evidence
is,
or for use of OPV in NICU by other units? Dr. Shiparna?
probably no. Like this is more of a myth than reality. I feel so. It's just a like feeling.
Did ethics
Don't.
people raise some issues regarding this?
I am not aware, but conventionally we avoid giving. We give it at
Yeah.
the
So
time of
using it
discharge.
for first time, did we tell the patients and other attendants that there is a risk involved which could be there?
Yes,
Was it
yes.
taken in the consent as well?
No, no, no. Actually, we give at the time of discharge. We do not give live polio vaccine. Like it is
Yeah.
our
So
practice to
for
give it.
purpose of research, we are doing this.
Yes, this is true.
So I think that's a ethical question as well, going
Yes.
against standard national recommendation. So that was something which comes to my mind.
Gaurav, you can unshare your screen, I think.
Dr.
If you want.
Mangla, Dr. Gaurav, Dr. Deepak.
Dr. Deepak.
sir.
Okay, so I have a few slides to share and to discuss about the study. Can I share the slides?
Yes.
Okay, let me know if you can see the slides now.
Yes, sir. Visible, sir.
Okay, so obviously this is, as we have seen from Gaurav's excellent presentation, a clear presentation and his critical assessment that this is a very well designed study. And I plan to look at a few things over next 10-15 minutes to bring about stance of the study and also to address ambivalence of many people that whether we should actually use BCG and OPV in our NICUs to prevent infection or not. So I have few things to discuss there. So few of the things which I have taken up are teaching points for our residents or attendees. So we will look at these 4 or 5 things, the sample size, how they have used a different approach to what usually we see. We'll look at their primary outcome, which is incidence rate, not risk of a outcome. Role of censoring, which Gaurav has touched, we will look at it in a bit more detail. Then method of outcome assessment, and finally, the thing we are discussing here about co-intervention with OPV. Now, if we read the sample size calculation paragraph of the study, which I reproduce here, so there is a bit difference here. First of all, they have started that with the assumption that the mortality rate in control group is going to be 15%. And looking at 95% power to detect a 30% reduction, which means a relative risk of 70.7, 30% reduction in mortality, and power alpha error of less than 0.01. So very good study power and ability to reduce any chances of false positive signals. So these are very good things. Both things are very good. And they then said that if you calculate by 15% rate in control group, 70% reduction, 0.7 of RR and 30% reduction in the experimental group. So we need to have around 510 deaths in total. So then they said that we will not target to recruit 1998 infants, which you get by sample size calculation, to reach the desired power and alpha error, but we will look at to reach mortality of 510 babies in the study. So this is sample size which is driven by number of outcomes, not by the number of subjects. Now, why this is important? Many times we see in different studies that this particular slide shows the assumption used in the study, power of 0.95. Relative risk of 0.7, alpha 0.01, 0.15 of proportion in control group. And if 0.7 RR is there, then expected event rate, that is death proportion in experimental group, will be 0.105, that is 10.5%. And we get a sample size of 1998 in both the groups, total of around 4,000. Now, if we do study like this, mostly we will see in published studies that event rate has reduced once we start the study. We start with the assumption that 15% babies will die in the study, but actually we will get maybe 10%, maybe even less than that. If that happens, then the power of the study is reduced because the event rate has reduced. The power of study, we start with 95%, but actually it will reduce. So if we see what happens to power of the study if event rate is reduced. So if from 15%, it is reduced to 14, 13, 12. So this column shows you what happens if the incidence of death reduces, what happens to power. So as you can see, if you keep the same sample size, same RR, same alpha error, if you keep on reducing the incidence rate of death in this case, the power of the study keeps on reducing. So if incidence rate instead of 0.15 is half of it, 0.08, then you end up with power of only 64% if you recruit only 1998. So this study was designed to keeping this in mind, that if the incidence of death reduces, we will lose power. So therefore, we will not look at the sample size of 4,000. We will look at 510 deaths. So actually, what happened in the study? So this graph shows what happens with control group proportion reducing from 0.15. So here it is 0.15. With 0.15, they had power of around 95%, which they have calculated. So what will happen if the incidence reduces? So if you look at in this study, actually they started with assumption of 15% death rate in control group, but actually in this study, they had death rate of only 10%. So instead of 15%, it actually happened the death rate was only 10%. So if they would have stuck up with sample size of only 1998 in per group, they would have reached a power of less than 80%, around 77 or 78%. But actually, they did not look at, they recruited only 1998. They continued till 510 deaths were reached. And because of that, they recruited higher number of subjects, around 5,000 instead of 4,000, more than 5,000, so that they retain the power of 95%. So this is one very good peculiar thing about this study. They preserved power by increasing the number of subjects recruited to reach the target death rate of 510. Second thing which I want to point out is difference between risk and rate. So risk, which we usually see in many neonatal studies, is cumulative incidence over a fixed window, that is death by 28 days. So this particular thing ignores how long each subject was observed inside these 28 days. If the primary outcome is at 28 days and a baby has been lost to follow up by day 14 or day 15 or even day 27, and you do not know what happened to at day 28, you will lose the dead baby's information. You can only look at babies for which information is available. So risk of death in that cases is total number of events divided by total number of subjects who have completed the study endpoint, that is 28 days. The rate, now rate does not look at only those subjects which have reached 28 days. It uses the denominator of person time. So the event, so numerator is same, events, but denominator is sum of the time at risk. So if a patient has been in the study only for 14 days, 20 days, so that patient's data will be used for 14 days or 20 days. So that patient will not be excluded from the study's analysis. So it increases the power of the study to detect any effect size which we may see. So again, very good part of the study is it looked at incidence rate and not only cumulative incidence. So this is very helpful, as the Gaurav also pointed out, that this allows variable flow follow-up period or variable at-risk period, or sometimes you have recurrent outcomes, not death, but if outcomes are recurrent, for example, ventilator-associated pneumonia or catheter-associated infections, then it is better to use sum of the time at risk in the denominator and number of episodes of VAP or infection in the numerator. Now, let's move on to censoring, because this is very important. Now we look at some of the things which could have, in my viewpoint, could have been done in a slightly different manner in this study. Now, what is censoring? Now, censoring is removing that time of the subject which you cannot observe, obviously, because if a subject has stopped to be part of the study because of being lost to follow-up by day 14, day 15, day 16, beyond that, you do not know the data of the baby, so that baby will be censored at that time point. So their contributed time point will stop before that. So schematically, if you look at what happened in this study, in study group, if you look at, let's say, any imaginary 10 babies, so this triangle represents BCG OPV. So at randomization, so if day 1 of randomization, baby receives BCG. So first subject, let's say, dies on day 1. Second subject dies on day 5. Third subject is included only till 14 days. After that, baby is lost to follow-up. So it is censored here. Your patient is censored here. Fourth patient goes up to 21 days, censored here. Fifth patient goes up to, so all other patients go up to 28 days. So they contribute till 28 days. These two subjects, third and fourth, contribute only till they are followed up, and these two patients are followed up only till they have reached the outcome. That is, they died at day 2 or day 6 of the study. In control group, what happened in this particular study? In control group, again, let's say the first two patients are same. They died on day 2 or day 5. Now here, very importantly, the BCG was received by maybe around 30-40% of subjects in control group, not at end of 28 days, but at the time they were discharged or they were transferred from an ICU to the postnatal ward. So for example, in some patient depicted by these 4 patients, the BCG was received on day 7, let's say by that time, because many babies, this study included babies less than 2 kg. So many babies will be 1.8, 1.9, 2 kg. They will get discharged by day 7. So they will obviously we will be given BCG at day 7. So at that time, so they received intervention, but they were continued to be followed up later on. Some babies received later on, like say day 14, and some babies also received at day 28 or beyond that, if they obviously they were discharged or shifted out later. So what this study planned to do initially was that, so they initially thought that if baby in control group received BCG vaccine at earlier than day 7, they will not include these patients later on. They will censor the subjects at this time because obviously they have received intervention. So they have become equal to the patients in the intervention because they have now received intervention. So this was their original plan. But DSMB said that it should not be done. Now, why DSMB thought so? Because what happens that most of deaths happen in neonates in first 2, 3, 4, 5 days, and very much smaller proportion of deaths happen beyond first 7 days. And as the age progresses, the chances of death keep on increasing. So in study group, you can see all this period, high risk period or low risk period, is part of the denominator. Whether baby is 1 day old, 2 day old, 28 days old. So all this is part of denominator. Now, what would have happened if control group would have been removed from the later part of the study where they have received BCG vaccine? So they are part of the denominator in which they would have been at low risk of death. Low risk of death would have been removed, while most of deaths would have already occurred in earlier period. So if that was done, your numerator is still high because very few deaths would have happened after day 7 or 14. So numerator would have remained maybe reduced by a very small proportion, while denominator would have been removed in large amount. So the event rate would be inflated. The control group death rate would have been inflated if we would have removed this low risk period. So DSMB said, don't do this. Include all the period which is there, which is whether babies have received BCG at day 7 or 14. Include them in your calculation of outcome in control group also. This was again very important change which happened in the study after the study started. Now, one very important thing about this particular table. So Gaurav highlighted that death less than 28 days, primary outcome occurred in 1.29 deaths per total person years in early BCG group and 1.50 in the control group. What would have happened if the later period would have been censored? So as was original plan, this was the original primary outcome. So as expected in early BCG, it would have been remained same because we have not changed the numerator or denominator. While in control group, they will have been inflated rate of death 2.25 because we have excluded the low risk period. So in that case, would have got a adjusted hazard ratio of even 0.78, even greater effect size as compared to if we had got by not excluding the low risk period, which we got as 0.83. So it is important to differentiate this change in primary outcome which happened in midway of the study. Now so till now we have looked at censoring, which happens on the right side. On the right side, that whether the patient who have received intervention should have been censored or not, and obviously censoring would have happened to babies who are lost to follow up. Now, what about censoring on this side? So now we have given an intervention which whose effect will not appear immediately. So we have given a vaccine whose effect will not appear in 1 hour, 2 hour, 3 hour, or 4 hours. So let's say even 6 hours or 24 hours. So should this period you can call as lag period. At this period or induction window of the study, let's say if it is 1 day, 2 day, 3 day, I have just hypothetically shaded 3 days. So should deaths which happen on first day or on the day of birth be part of the study? This is very important question because this is not going to be affected by vaccine. So this study did not look at doing the leftward censoring where the vaccine would not have had any effect. And we know that maximum number of deaths in newborn babies happen on the day of birth. Now, this is again very important. If you look at the same table and look at time of death, where the most of deaths were reduced in this study, highest reduction in death occurred in first 2 days. So that is 2.53, here 3.41, and you get a maximum effect size of 0.72 here in the first 2 days. Then in next 3 to 6 days, it is 0.84, and in 7 to 27 days, again, it is only 0.9. So it is very important that reduction of death is happening in 0 to 2 days. And I think authors were very aware of this. And that is why, if you read the discussion, they have mentioned that BCG was not only preventing infection, actually it was treating infection. So if baby is dying in first 2 days and you are saying that deaths are being reduced because of infection, you're actually saying that BCG is not preventing infection, it is treating early onset sepsis, which to me is still very hypothetical. Now let's move on to the next important issue in this study. Now we know death is a very hard outcome, and it is very good that the study was powered to look at a very, very hard outcome of death. But one very important thing which I believe should have been done in this study was to blind the person who assigned the cause of death. The cause of death was assigned by the clinical team, which obviously, because this is a non-blinded study, who knew that whether baby has received BCG or baby has received control. Now look here. So this is the table, and here I have produced a dumbbell chart which shows the difference between the two groups. So if you look at infection, which clearly Gaurav pointed out, the ratio is 0.55. In infection group, in early BCG group, 31% death occurred because of infection. Here, 49% death occurred because of infection. This is the large reduction. But look at hyaline membrane disease. 34% deaths occurred in hyaline membrane disease in early BCG group. 23% deaths occurred in control group. Now, hyaline membrane disease cannot be treated or prevented by BCG. Then we look at asphyxia. 10 deaths occurred here because of early BCG group. 1 death occurred here, which occurred in control group. Then we have malformations here. We have IVH here, although IVH is not different. So I think one thing which I think is these deaths should not be included, especially HMD, asphyxia, malformations, or maybe deaths which happen within first 12 hours, 24 hours at least, because these are not being are very unlikely that these will be affected by BCG. Second important thing, we know that in many times when we assign cause of death, we will have dilemma in low birth weight babies. A baby is born, a baby has bilateral opacification, mother has risk factors, preterm labor is there. You give surfactant, to give antibiotics also, then baby dies. You classify death whether as infection or HMD. It is many times not possible to differentiate. So when you have this imbalance of deaths with infection being higher in control group and HMD being lower in control group, I don't know, because I believe that if this adjudication would have been done by a blinded person, it would have been much, much better. And I think the last point which I want to bring about is the co-intervention point. We should not ignore that the BCG worked only when it was given with OPV. So the deaths are being reduced. There's no doubt that deaths are less in BCG OPV group. There is no doubt about that. That is a very hard outcome to effect. So BCG OPV is reducing deaths. Not BCG is not reducing deaths. BCG OPV is reducing deaths. And BCG is not secreted or spread in NICU, but OPV, we know that if OPV baby receives OPV, OPV will be secreted in stool. That is why it has herd effect. So OPV will be secreted in stool. It will spread in NICU. But if you're giving to every baby, I think we should not be fearful that OPV is spreading to every baby. But I still think that what happens to immunocompromised babies who are extremely low birth weight babies, because the number of ELB babies is very small in this study. What happened to babies who have severe infection in first few days, or who have although very small number who have received the intrauterine transfusions. So there will be some cases in which we will need to think that whether these babies should be isolated from babies who are being cared for in NICU and are receiving OPV. I think these are all the slides I had. I will stop sharing, but I again will end up with saying that this is an excellent study, and I will congratulate Dr. Mangla. I can see Dr. Adi Shivam is there in the participants. I will congratulate both of them and conducting and publishing this excellent study. Over.
Thank you, sir, for the wonderful
Thanks for the
deliberation.
excellent analysis, Dr. Deepak. We are really much wiser, though I would admit that still almost 50% I couldn't understand what the details of statistics, being a core clinician now, but a lot of people would have gained. It's an eye-opener for a study. And Dr. Mangla Bharti, who was part of this trial, isn't it, Dr. Mangla?
Yes, sir. Yeah.
So your comments, especially, were you surprised with the results of the study, or you were quite confident that, okay, this will help?
Yes, sir. So, first of all, our sincere thanks on behalf of our whole team and all the authors to NNF for taking up the study in the Journal Club. And so this trial, so even though I am here today, Professor Frank Sean was the mentor and he was the pillar for this whole trial, ably supported by Dr. Siva Namichvayam. Also, our profuse thanks to our seniors, Professor Vishnu Bhatt and Kumata ma'am, so our teachers, so who initiated and brought this trial here, and colleagues, Dr. Adisivam, Dr. Kamal Ratnam, and our whole team. So maybe I'll just quickly give a short background, which will answer many of the issues which might help in people understanding. First of all, why bring in OPV and why the dose between 0.05 to 0.1 foot. There are many questions raised throughout. See, this is the second trial that we have done on this subject. So you can refer to a previous publication that we have done in Pediatric Infectious Disease Journal. That was a BLOW-1 trial. So which is the first trial we undertook on this subject of looking into the innate immunity effects of BCG in helping in decreasing neonatal mortality. Because at that time, the studies in Africa, the results were there. It showed a significant reduction in all-cause mortality. So that's why we took up the trial. But to our surprise, even though that trial also had a very good number, more than 5,000 babies in total, including both the arms, we were not able to show any difference in mortality. Otherwise, more or less, the inclusion, exclusion criteria, everything was the same. But in the trial of the two centers or three centers, Zipmer and our intramural and extramural centers, ICH and IOG, the practices were different. That's why we published it as two different studies actually in the previous BLOW-1 paper, even though it was a single paper, because Zipmer, for quite some time, they were using 0.1 ml of BCG even before they started the BLOW trial. This was their practice for a longer time. Whereas we were using only 0.05 ml of BCG conventionally. Also, Zipmer was using OPV along with BCG, whereas as rightly the concerns were raised, going by the concerns of using a live vaccine and spread of OPV to immunocompromised neonates, we were not using OPV at the trial. So we looked into the BLOW-1 trial. the two different the studies. One study from Zipmer using BCG 0.1 ml dose with OPV, and our study from ICH and IOG using 0.05 ml of BCG with no OPV. Surprisingly, even when we did a subgroup analysis, we were not able to find a difference in mortality in both our studies. So that actually made us probe more into maybe it is more related to the strain of BCG, because the previous studies has used a Danish strain, whereas we had used a Russian strain, because that was the one which was easily available and was supplied by the government also to us. So when we ventured into the second trial, so we thought where primarily we wanted to again retest this using the Danish strain, believing that that may be the reason why we didn't find a difference. But in this study again, so at least for being a larger trial and learning from the Zipmer's experience, where they have been using a 0.1 ml dose for a very long time, without any adverse event reported in their center. And also, as I said, the previous trial, there were more than 2,000, close to 2,700 babies who had received BCG 0.1 ml with no adverse events reported there, and use of OPV. One more reason is that there is evidence to show that when we talk about the effect of a vaccine like BCG in improving the innate immunity, this effect seems to be facilitated by live vaccines. And also there is a reason to believe that actually whatever the effect the BCG brings in might get offset the moment we start using another killed vaccine. So live vaccines might potentiate the effect of BCG, and killed vaccines may have a negative impact. So I fully agree. I think this design cannot tease out whether how much benefit came from BCG and OPV, but we believed adding OPV could actually enhance the effects of BCG if it is going to be there. And we wanted to have an uniform protocol. That's why we switched in this trial. Also, our systems, both ICH and IOG, we moved to 0.1 ml, and also again add of OPV. One more thing we improved upon was actually in the previous trial, again, we were a little bit concerned about various people administering BCG. We know that there could be problems with the technique of BCG administration. So we used trained personnel who are earmarked for administering BCG in this trial at all the centers, and they only administered BCG in this trial. This is the reason for bringing in to answer the dose of that one and the use of OPV, why we brought in OPV. And I think, sir, only just the question, sir, I fully agree with Deepak, sir. So thank you, sir, for teaching us excellently the row censoring. And so already Deepak, sir, has explained why actually the DSMB advised us to actually not to do censoring for babies when they have received BCG later, before discharged. That was well discussed. So coming to the other side, so whether actually in the early part, whether that might have made a difference. And the second concern raised by Deepak sir was whether there are so many diseases apart from infections, which there seems to be difference, like HMD. So we believe that if you look into the thing that's in table number 3 of our paper, look into the median time in which the administration, we have looked into the usual the time taken for administration, that comes to a less than a day. It's 0.9. So most of these babies have received, and even the intervals go only up to 0.6, the CIs. And the results start from 2 days onwards when you look into the death and all. So we believe most of the babies have received BCG before the deaths have started happening, as all of them have received earlier, but not every case. I fully agree about the concern, but this is one point that I wanted to make. And that's why in discussion, we have just said that the disease could have been in progress also, so that it could have acted as a treatment rather than a prevention. Regarding the second one, etiology and taking only infection-associated deaths. So we all know that actually the challenges especially in LMIC, in diagnosing neonatal sepsis with confidence. So that's why our primary outcome was an all-cause neonatal mortality. Actually, this outcome infection associated was added much later into the study when we have already enrolled more than a third of the babies. Again, it was based upon a DSMB suggestion, at least to prove the hypothesis, because if we show some effect and we don't know how it works, so people said that we should be adding this, and that was added much later only. We wanted to restrict ourselves only to all-cause mortality because pragmatically we thought that will be the right kind of parameter which will be acceptable to all in an LMIC setting, so that the results can be extrapolated or generalized more. So these are my quick comments, sir. I'm open for answers if there are more queries.
Do we take a couple of questions which are there? So people are asking questions anonymously. So the anonymous attendee has asked a question. Congratulations to all the authors for conducting a well-executed and meticulously designed trial. However, I would like to inquire about the rationale of undertaking this study. What is the actual incidence of tuberculosis or polio among NICU graduates with current protocol? Is this truly a significant clinical issue in studied population? Furthermore, would vaccinating a newborn prior to NICU discharge not be more feasible than and contextually appropriate strategy? So probably this person is confusing using this for prevention of tuberculosis or polio, isn't it? When the aim was not to reduce polio or tuberculosis in these babies. Your comments on this, Dr. Mangla?
Yes, sir, absolutely, sir. Because the whole idea is about the non-specific effects of BCG. That's the whole idea of the study. So in the non-specific or the heterogeneous effects of BCG, we call the excellent slide shown by Gaurav. Thanks, because this actually primes and enhances the action of the natural killer cells, which are part of the innate immunity by epigenetic modification. So that is the principle by which we believe BCG helps.
Your hypothesis was about 15% reduction in mortality in your sample size calculation.
Yes, sir. So
I
that
was
was
wondering, how did that 15% reduction, why did you take that as 15% reduction based on what?
Thanks for the question, sir. So in the control arm, we had taken a mortality of 15% actually. That is from our previous Blow 1 trial, when we had done a trial already. In that trial, the mortality in the control arm, the non-BCG arm, was around 17%. So we had taken a number of, we anticipated the same to be here around, maybe with time it might have a little bit improved also. There was nearly a gap of more than 3 to 5 years between these two trials. So we chose around 15 for the control. The reduction part, when we talk about the relative reduction of 30%, which was the effect size, that was taken from the meta-analysis. That was mainly coming from the African data. They had shown around a 28% reduction in the meta-analysis. So even though we failed to show it in the earlier trial, we believe with the Danish, we may be able to achieve that. That's the reason for taking the 30% effect size.
So this raises one question that about 20%, 17% is the mortality under 2000 grams
Yes,
in the
yes.
control.
Overall, sir.
For
Overall.
inborn babies, is that mortality a bit highish on the higher side for an institutional delivered baby and always in observation? So what is your comment on the mortality rates observed in this control group as well?
So all these, first of all, actually, I agree that many of them are inborn babies, a significant proportion. But this trial included both inborn babies and outborn babies. Zipmer they cater to, their unit catered to both inborn babies and outborn babies, predominantly inborn. As far as, but our centers, the two centers at MMC, ICH and IOG. IOG is an exclusive intramural center and ICH is an exclusive extramural center. All the babies, that's why if you look at our inclusion criteria, it says that we enroll up to even up to say 21 days when we are having to extramural babies also. And this is again babies of different levels of sickness. We didn't have any lower gestation or lower birth weight for exclusion. We just only had a very pragmatic criteria If only the clinician feels the baby is unlikely to survive in the next 24 hours, it's more likely to die. That was an exclusion criteria. Beyond that, we have not excluded anybody based on birth weight or a gestation. So, but
Data doesn't differentiate between intramural and extramural babies. So is the mortality different between these two subsets,
no,
intramural
sir,
and
no.
extramural babies?
Subgroup analysis, it worked well in both intramural and extramural.
It was saying. Okay, thank you. So going on to the next question is, with advances in microbiological diagnostic techniques, would ruling out BCG-osis and OPV-related infection help more accurately define mortality attributable to vaccination? So, Dr. Mangla or
Because we, I think this is more related to the previous question what we discussed. We are talking
yeah, exactly. So it is not
here, not
yes,
BCG associated.
not BCG or then the next question, how do we explain the AHR of mortality 95% CI crossing 1 in individual birth weight subgroups in table 5 and overall AHR of mortality shows significant difference? So you have to see, probably you will have to see the table 5 for that.
No, the table 5, I think, I'm not sure whether people have understood the table. So overall, the results are shown in the primary outcome. Here, the p-value, what it is shown here is actually to see if we stratify groups by these various likely confounders like birth weight, gestational age, maturity, sex, the location, intramural, extramural, mode of delivery and all, is there a difference between the two groups? So the p-values are all non-significant here, saying that even when stratified by these confounders, the effect still remains there.
Yeah.
And of course, obviously, when we do a subgroup analysis, we can't expect the same CIs
Yes.
like what we have in our primary.
It's basically overall data which is taken over rather than subgroup analysis. So do you think to simplify things for average audience, instead of having rates as death per total person years, if you could have had just said about mortality in number and percentage in less than 1,000 grams in each group, how would that have made a difference? In just a simplified overview of mortality based on gestation and weight.
That part is also done for the main primary outcome, sir. That's where the number needed to treat has come. Only when we just look into a percentage, you just know you get the risks and risk differences. And from that only the NNT is calculated. But I think Deepak sir, we listened to Deepak sir and also Gaurav also brought it out well. Actually, the benefits or the advantages of using rate as an outcome compared to that of the risk and the rate. So when we have a better outcome, when you've chosen a better outcome, a rate over a risk, why to go back to risk again?
Definitely.
So
It is statistically better to depict.
I think Deepak sir has raised hand. He wants to answer that.
Yes, Dr. Deepak.
So I think originally the study wanted to censor the babies in control group once they received BCG vaccine. So they wanted to include only that period in which BCG was not there. So that is why the primary outcome originally is rate and not risk.
Okay. So the next question is, was it practically difficult to administer BCG in sickest ELBW babies? Was ethical clearance a difficulty for OPV and NICU?
So no, I think
Dr.
for this trial, it was easy. The first trial, obviously, so it was there were concerns, but as we have done this in 5,000 babies earlier in the previous trial, it was easy for us to move through the ethics for the second trial.
How many parents refused consent for this?
I think I'm sorry, I don't remember the exact number.
Approximate.
There, sir, in the table 69.
69.
69.
So were they told about the risk of,
Yes, sir. So the standard patient information sheets were used and informed consents were taken.
Okay. Dr. Manish Vittal has asked a question. Is this just a observed factor that BCG prevents early onset neonatal sepsis, or is there any physiological mechanism as well?
So That's the proposed mechanism, is in obviously strengthening and enhancing innate immunity. And actually, there are bench studies available to show that this happens, the change, what happens, what are the epigenetic modifications that have been discussed in the initial literature review of the paper as well.
Yes. So the next question is same as has already been discussed. Very meticulously conducted study, sir. Curious to know the background of such a study. How does the idea start? So if you could just briefly answer him in a minute about this primary outcome being sepsis and mortality with use of BCG.
I think quickly in one word, it's all thanks to Professor Frank Sean and Professor Vishnu Bhatt and Kumta ma'am. So I think Professor Frank Sean was part of the trials in Africa as well. So he had that idea for quite some time based upon the bench studies. They had and he was closely observing. He had a very keen interest in immunology. So when he pitched and floated the idea, obviously our mentors, Professor Bhatt and Professor Kunda ma'am, they thought it will be very useful we should try it up. That's where this all started.
Dr. Frank Sean is, he is originally from your institute or?
So he's from University of Melbourne. Sir.
He's from, has he conducted a similar trial in Melbourne?
No, sir. Not in Melbourne, sir, but he is part of, especially because this is being, he was actually looking into interventions which can make a significant dent in mortality, especially in LMIC. So he thought this is one such intervention, though the trials are primarily, so far they are mainly in LMICs. I'm not aware of trials conducted in developed nations.
Yeah, because like I at times get wary of foreign faculty coming over and giving ideas. Okay. So next question is, could adjusting for causes of death that are significantly different in both groups add more clarity to primary outcome? Cause of death you have already mentioned. Causes of death are significantly different in both groups. So sepsis is one. Anything else? HMD?
Yes, Deepak sir had shown the slide. So we were interested only in infections. The other group also was a little bit different, HMD and all. Because that was, but not our motive. It was, the intention was to measure only all-cause mortality.
Some kind of random variation will always be there. You will have some number high in one group, some number high in another group.
Yes. And so next question is also related to infection. What about cross-infection to other neonates with OPV? Was it studied? Obviously, like sample size is too less because OPV as such doesn't. So Dr. Mangla and Dr. Deepak, do you have, can you give a sense of like previous data before this study, but historical data of outbreak, any outbreak in OPV due to OPV being observed in NICUs? Why this recommendation of not giving OPV in NICU came over? Was it only a hypothetical risk, or there was some study has shown some risk of NICU outbreak with use of OPV earlier? Any, not related to this study, but yes, actually related to this study in some way or the other.
Sir, actually, I am not I have not revisited that literature recently. But as I told you clearly, in our previous trial, we were not using OPV like everybody else. We were worried about bringing in OPV into NECU. We were then. So, but we just got emboldened by the use of OPV for a quite long time. I think Dr. Adi and Dr. But will be able to answer this question much better. If they are putting something in the comments, I can pass on to the group also. From their experience, they were very confident OPV doesn't cause any trouble in the NICU. And
so how long have they been using this in NICU?
They said quite long, sir. They only have to answer for that. I don't exactly know that.
Okay. So so next question is, are the units continuing to give BCG and OPV to LBW and preterm neonates within 48 hours? So once the trials stopped, probably in 2022, when did the trial stop?
22, yeah.
22,
because
isn't it? Yes.
when we reached
so are we still using it as a policy in your unit right now?
No, we have just analyzed and written the paper, sir. Definitely, we are about to bring it into practice. No, we didn't because
Any follow-up data for last 3 years? So is only neonatal mortality reduced or infant mortality was also reduced?
no, sir. We were not able to. We don't have the follow-up data as of now.
It would have been wonderful to follow
Yeah.
up such studies to know
We have
infant
plans, sir.
mortality as well.
We have
But
plans.
it is very difficult to have a population-based study to follow up. So we know how difficult it is to follow such kids after discharge. And so the last question by Dr. Manish Mittal is, was hepatitis B also given simultaneously? If not, then when was it given? So Dr. Mangla,
Sorry, sir. Sorry, I missed the question, sir. Sir, please.
was hepatitis B also given simultaneously?
No,
If
no,
not,
no,
then
no,
when
sir.
was it given?
No, sir. Hepatitis B was given only when they came for routine vaccinations later to the immunization clinic.
Okay.
Yeah,
I'm
because
surprised because Dr. Frank, being an Australian, and when I was there in Australia for a couple of years, all babies received hepatitis B at birth.
yes, sir.
At admission, even ELBW babies at birth with vitamin K would receive hepatitis B.
Yes, sir.
And so he has designed the study and he has used only BCG and OPV, but not hepatitis B. So that is
But,
also
I think, Professor, but also, sir, I'm not sure whether they're
interesting to know.
using BCG and OPV in Australia because many of the developed nations don't use BCG. And so, say, sir has said, Vishnu Bhatt sir had said they don't use BCG in Australia. And
So Pratima, can you move Vishnu Bhatt sir to panelist so that he can speak?
Yeah.
Yes.
Is Dr. Vishnu Bhatt sir here?
He's around. He's around. He wants to speak up. So maybe.
Dr. Adiswam also is there. Both of them can join.
That would be wonderful to have them and listen to them.
Who is host now? Host is Pratima. Pratima, you will need to move sir from attendee to panelist if possible.
We can send him the link. He can join the attendee panelist link. Dr. Debrun, if you can just send the panelist link directly to sir. Dr. Vishnu Bhatt is writing. So we can read what sir has written till. So Dr. Vishnu Bhatt, sir, till he joins, what he has written till now is they do not use BCG vaccine in Australia and other developed nations. That is true. And the reduction in mortality gets blunted after killed vaccines are administered. So the window for reducing mortality is very less. I would think it
But
before
that's,
6 weeks vaccine is given. Okay. And one question from Dr. Ashok Kumar sir goes that what was the blood culture positivity rate in control versus experimental group? So was this sepsis all culture positive sepsis or was it both culture positive and culture negative sepsis?
This is this is a combination of culture positive and probable sepsis.
So if you look at culture positive sepsis, Dr. Mangla, what does the data say?
Sorry, sir. That's it's there in the supplemental tables. Maybe just
Dr. Frank, like you, I'm sure you would have looked at that data about culture positivity and culture negativity. That is something which every neonatologist would be interested in knowing.
It was different. I don't have the exact numbers, sir.
Okay. Similar or just
No, it
about
was
the same?
different. It was different. Both culture positive as well as the overall culture positive and probable. Both were different in the two.
Okay. Dr. Vishnu Bhatt sir has a message to say over here. We are so happy just reading his messages. Blood culture positive and negative. Culture positivity, if I remember correctly, about 40%. Both culture positive and negative, sir says.
Yeah. So in the meantime, may I ask Dr. Deepak sir a quick question? Just when we are waiting for.
Yes.
Sir, I was very curious about your idea of adding censoring upfront also. Is it a standard way, and how do we bring in censoring upfront also? Based on what? Is it okay to bring in censoring in the front end also?
Dr. Mangala, I think it is fairly common in many studies which have been done. For example, if you look at the effect of intervention to reduce cardiovascular deaths, or which will have some time to reduce cholesterol, to some time to reduce. So that time period, initial time period, I think should be excluded first few time. It is well established. This left-sided censoring in addition to right-side censoring.
Okay. Thank you, sir.
Sir, a couple of questions have come up. So just a small thought, was probiotics used in the study and control group? So are you a probiotic using unit?
No, sir, no probiotic.
No. So Dr. Manish, the answer is no. And Dr. Poonam Singh, India asked the question that India is intermediate endemicity region for hepatitis B, for which WHO recommends first dose to be given within 24 hours of life. I'm not clear why hepatitis B first dose was delayed.
Yeah, I fully agree with your concern. But if you compare these two, like the load or the significance of neonatal mortality in less than 2 kg babies compared to the load of congenitally transmitted hepatitis B infections, what we are facing. And because this is a specific study targeting only less than 2 kilograms babies, where mortality is a big concern. And we believe a simple intervention can bring a major change, which there is a concern which might get offset by a vaccine which is a killed vaccine like hepatitis B. And I don't think it is a standard practice as of now to give hepatitis B to all babies, irrespective of their hemodynamic status in less than 2 kgs also. So these are the reasons why we didn't administer hepatitis B. But when it comes to framing a policy, I fully agree all these concerns needs to be addressed and taken into account.
So that's wonderful. I think all the questions are over and we are over with the time as well. So Dr. Deepak, Dr. Mangla and all experts, can we close now with the important? So would you recommend, based on the study, that everybody watching this webinar and those who are not should be giving OPV and BCG to all the babies in NICU from tomorrow? Do we have the conviction to say that? Will the government of India follow the trial results and use that in their will the IAP change? What do you think? What would you recommend to IAP, which brings the vaccination protocol every year?
Yes, sir. So again, thanks for the
Should
question.
we wait, or should we wait for more trials, or should we begin right away?
I'm not sure whether it is our call, but as authors of the paper and being a reasonably larger trial conducted in a pragmatic way in our own country, and we believe definitely the results are very important. And so we are in the process of disseminating and discussions with policymakers. So we believe and we look for policy change based upon our paper. But of course, I think a lot of things will be discussed before policy changes. We do understand.
Before, like, one thing comes to my mind, in India, BCG rate is not 100%. We still don't have universal, and with the lakhs and lakhs of babies being born every year or every month, you can say, looking at neonatal mortality, can't population-based data be found out with our outreach? Many comes for six weeks. Vaccination is really very high. So if we have data of babies who are vaccinated at birth with BCG or not, you can have a couple of lakhs of babies in the two groups in a year or so, and you can have a population-based data as well.
Yes, but the window seems to be very small, sir, because
6 week first vaccination, you
first
can
vaccination starts with 6 weeks.
But babies who die won't be coming for 6 week vaccination. So that is a difficult thing. Okay, so thank you everybody. Thank you, Dr. Deepak, and thank you, Dr. Sparna. Thank you, Dr.
Thank
Mangla.
you. Thank you.
Thanks, Dr. Sindhu, and
Yes,
Dr.
sir.
Pratima, Dr. Ramesh, Dr. Saurabh Datta in absentia. It was a wonderful day. It was we missed having Dr. Vishnu Bhatt, sir. If we had a clue that we would have joined him on panelist link beforehand itself. Over for now. Next month, again, we will be back with some new journal, equally pertinent and clinical issue to be raised and discussed. Till then, goodbye from NNF.
Okay.
Bye-bye.
Thank you. Bye.
Thank you. Thanks, everyone.
Thank you.